All right. So we showed people a study, 132 trials, over 7,900 patients, and we described the results. Modest short-term pain relief, no long-term benefits, and potential serious complications. And then we asked, would you still recommend this treatment? And people lost their minds. They said things like, this is why chiropractic is pseudoscience, or dangerous quackery. This should be illegal. But there was one small problem.
It wasn't about chiropractic.
That's right. It was epidural steroid injections. The thing that your doctor recommends after an MRI shows a bulging disc, the real medicine option. Same weak evidence, but somehow when a physician does it with a needle and a fluoroscopy machine, nobody calls it quackery.
Today we're talking about why the exact same data gets a pass or gets crucified, depending entirely on who's holding the syringe or, in your case, whose hands are on the spine.
That's right. This is The Pitch. What happens when a chiropractor and a physical therapist get together to make a health and wellness podcast?
But chiropractors and physical therapists don't like each other.
Oh, think again.
I'm Dr. Kathy Lynch, physical therapist who likes to help people move and get stronger.
I'm Dr. Jason Young, an evidence-based chiropractor who uses humor just as much as adjustments to help people get better.
Welcome to the Pitch Podcast.
Remember, there's no I in pitch. Kathy, we're back.
Hello.
Yes. Hello, everybody. I'm Dr. Jason Young.
And I'm Dr. Kathy Lynch.
Yes, and this is our podcast, the Pitch Podcast. How are you doing today, Kathy?
I'm doing pretty good.
You're doing pretty good.
Pretty summer basketball. So,
yes.
Yeah, it's a good day.
For the high school. Mm-hmm. How are the Spartans doing?
Hey, shout out to Coach Dan.
Yes.
The future
Coach
is
Dan.
bright.
We know that Coach Dan is out there listening.
He is.
Every single time.
Mm-hmm.
So have you guys played games?
We have a controlled scrimmage tonight. We got some games this weekend. So,
all right.
Yeah.
All right. School full of ballers.
That's right.
I love it. Yes. And, we're taking the summer off from sports since Alston's knee is still healing. Mm-hmm. Definitely on track. Okay. And he's asking when he can come back for the follow-up.
I think we need the follow-up because soon to run this week.
Yes. He's excited. Mm-hmm. I think he's trying to keep it a secret from us, though, so we're not like, go running.
Oh.
No, Mandy declared that for the youngs, this is going to be hot girl summer.
Okay.
Yes, which is something that I had to look up.
Okay.
But she said it's not about our health; it's about looking good.
Okay, so, I love it.
Yeah, I've got to get bikini fit. So, hey, shout out to Karen again.
Yeah, Karen.
So, good stuff.
All right.
Well,
our episode, good stuff today.
Yeah, and so we did that whole kind of tease in the cold open, and I feel like we covered all the information. So, Raul, we'll just roll the closing credits. I think we're done. Everybody's got the point.
We're done here.
Now we're gonna go hard in the paint on this one. So, Kathy, do you ever refer people out for epidural steroid injections?
I actually do.
You do?
I do when it is we've tried everything and the person's still in significant pain.
Yeah. It is kind of the court of last resort, so to speak. Mm-hmm. But did you know that most of the major guidelines put epidural steroid injections squarely after you and I in the pecking order? Yeah, it's true. I guess we should talk about what they are.
Yeah.
Right. So, an epidural steroid injection, which neither of us do because it's outside of our scope. Yes. So take that with a grain of salt. But epidural, the word dural, it describes kind of the wrapping paper around the brain and the spinal cord. Epi means near. So it's an injection that's near kind of that wrapping paper around the nerve that leaves the spinal cord, goes out to your arm, your leg, wherever. Okay. And steroids, that's like cortisone, things like that. And so the theory behind this is if you have an inflamed nerve, then you inject some of these steroids near that nerve, and it helps the inflammation to die down. And there's a few other types of procedures too that we're going to kind of cover today. Another one is called a facet injection. So the facet joints, that's basically where you have one vertebrae that overlaps the other, and it's got its own kind of capsule, And those capsules move just like any other joint, like a knee joint or an elbow joint or anything like that.
Little knee joints in your spine.
Exactly. It's your spine knees. Yeah, your spine knees. But there's fluid in those joints. Sometimes those joints will get inflamed, and sometimes they might do injections in those facet joints as well. And then there's another procedure that kind of gets wrapped up in this too that is called radioablation. And so this one sounds crazy, but basically what they do is they go in and using radio frequencies, they essentially burn the nerve.
Right.
And so when you burn the nerve, it doesn't work anymore.
Yeah.
And so if you have a signal that's constantly being sent that's causing you like sciatic pain, true sciatic pain, which goes where? Down past the knee. Yeah. Then, the idea there is, hey, let's interrupt those signals so that you can get moving, get active, and things like that. So that is kind of the groundwork that's laid. Now, these procedures are incredibly common, very common. Do you have any guess as to how many are done every year?
Every year?
Yeah, in the U.S.
Hundreds of millions.
Well, the epidural steroid injections alone are 9 million.
Oh, wow.
9 million injections a year.
Wow.
Yes.
That's it. I would have thought more.
Yeah. Well, they're actually on the
maybe just in our area.
Well, I think they're on the decline because I think the guidelines have even changed.
Okay.
Yeah, like last year, was it last year? Yeah, I think it was about a year ago. I had a patient who came to me and she was doing pain management, and she said, "Hey, the pain management doctor is recommending that I get epidural steroid injections. So what do you think?" And so, I've got my opinions, but I decided let's go check the evidence.
Yeah.
And what popped up was actually the level of recommendation for it got downgraded.
Did it really?
Yes. There's a good reason for it. Yeah. They're just not that effective.
So for facet joints or for disc, was there a difference between the two? Like whether it was effective for either?
That's a good question. So yes.
Okay.
So first of all, there's a few reasons that somebody might get some of these injections, right? And first of all, I already said first of all, so I guess I'm on second.
Okay.
Yeah, thank you for holding me to that.
Sure.
Third of all, sorry. Second, so first there's a reason. Okay. Now I'm all confused. Okay. Letter C.
Yeah.
All right. Nobody's getting these for acute back pain. Right. So you're not waking up one morning, or you're not like, picking something up in your garage, and then it's like, oh, I tweaked my back. Let me go get an epidural steroid injection. So that's not how they're being used. These are typically being used for people who have chronic back pain.
Okay.
Chronic back pain, the arbitrary definition is 12 or more weeks of back pain. And so, when we look at these kind of different classifications of it, there is back pain, which is just local back pain, meaning I've got pain that's right there in my spine and nowhere else. And then there's something called radicular back pain, which you know that word. Be honest, when you learned the word radiculopathy, did you think that they were trying to punk you?
Yes.
Yeah. It's like, this is the stupidest sounding word.
Ridiculous.
Oh, I've got radiculopathy. Okay.
Sure.
So you want me to just show up and say that to somebody? Like, would you like me to film while I do? Sir, you've got ridiculousopathy, right? Okay, but it's a thing. It's a real thing, okay? Radiculopathy comes from the same root as radiculation or ridiculation. That might be a word, but it doesn't sound like one when I say it.
I don't think it is.
Right, radiation,
there
right?
You go.
So it's
radiating from.
Yes, symptoms that radiate from the spine. They're called radicular symptoms or radiculopathy. And so that is like the pain, numbness, tingling, muscle weakness that's shooting down your leg or your arm or whatever. So epidural steroid injections, they don't even help with pain.
No.
They don't. Like, at least not according to the evidence.
Okay, what do they propose to help with?
It's a great question. Yeah, and I know, and I'll just say this. First thing,
Yes.
first two things, okay?
Yes.
First thing, and I'm getting these in order now.
Okay.
We're not giving any healthcare advice.
No, this is entertainment.
Entertainment. Woo,
Yeah.
disclaimer, disclaimed. All right. The second thing is that somebody's probably listening. They're like, well, this is no, because I had this done and it did help with my pain.
Mm-hmm.
And so one thing to understand about studies is that studies are not real people, right? The only type that is a case study.
Yes.
A case study is a study of like one person, one case, and you can't really generalize it to everybody. But the things that are more generalizable, there's going to be exceptions. And so if you're listening and you're disagreeing with me, then you're probably that exception.
Yeah.
And also, if you're disagreeing with me, you're disagreeing with what the study
says. Yeah.
So you and me, we're still friends. Yeah. Hey, Kathy,
Yeah.
what was I talking about?
Quick question.
Yeah. Quick question, Kathy.
I think it's about radicular pain.
Yes. Oh, and what does it actually help for?
Yes.
Yes. Okay, yeah. So these aren't good for pain.
Yes.
They sometimes help pain, but you get short-term outcomes, anywhere from a couple of days to a few weeks.
Mm-hmm.
To I've even had some people get them and they just feel awful. They feel worse.
They don't love the steroid.
No.
Yes.
But the thing that they're most effective for is disability. So, for example, if somebody cannot get up and walk because of their radicular symptoms, then this is when something like this might be on the table, might come into play, might be useful.
Mm-hmm.
Outside of that, though, if you're like, man, I've got this chronic, annoying back pain and this might be the thing that just like gets it done. Yeah, probably not. So,
okay.
So yeah, decent for disability, not effective for pain.
Okay.
You want to know a secret?
I do.
It's a dirty secret. It affects both of us.
Like, as people?
No, as professionals.
Oh, all right.
Yeah. There isn't a whole lot out there that, according to studies, is really super effective for low back pain.
That is the truth.
Yeah.
Yes.
They call it low quality evidence.
Mm-hmm.
And so people are like, that's not true because there's really high quality evidence for exercise. Not so.
Not really.
Yeah. It's rated very low to the low end of moderate.
Right.
Yeah. And there's a few reasons for that. And when you look at these studies and how they're done, there's something called heterogeneity, which is like when they're making these decisions, they'll have maybe like, you know, and the one that we talked about in the cold open, they had, what was it, 132 studies that they looked at. The quality of evidence gets downgraded if those 132 studies aren't very similar, right? Like you might have one that looks at a whole big group of people. You might have one where they used a certain type of needle and another one they use a different type of needle, or the dosages aren't the same.
Not reproducible, right?
Yeah. So they're kind of all over the place, and that brings the quality of the evidence down.
Okay.
Same thing with exercise, because do you prescribe all the same exercises as every other PT?
Yes.
You do. Okay.
Clamshells.
Yes. 3 sets of 10.
Yeah.
Right?
Yeah.
So yeah, that's one of the issues with all these studies is everybody's got kind of different kung fu. With chiropractic, one of the issues is there's like 100 different technique systems. And so when you say spinal manipulation, what does that mean?
Yeah.
Could mean a lot of different
things.
That's
a really good point. Yeah.
Yeah. So that's why the quality of evidence tends to be low. But low quality evidence doesn't necessarily mean that like the data is fake or it's not good, because even low quality evidence can help us to see a direction. So what I mean by that is you can have a study that shows that like maybe we're looking at things on a scale of 1 to 10. Right? You can have a study that shows that your treatment, which is clamshells, 3 sets of 10, right? That
especially for back pain.
Especially for back pain, right? Definitely. And fixing their weak core, right? And turning on
the glutes.
The glutes. Yeah.
You have dead glutes.
Yes. Reviving the glutes. Gluteal resurrection. Okay. that can give you like maybe 5 points of pain relief, right? Um, and so comparing all these different studies and everything like that, you might find that there's a varying number of the magnitude of the effect. So when we say low quality of evidence, that's what we're talking about is the magnitude. Is it 5 points? Is it 2 points? Is it 1 point? So we can't really tell. But when you look at all these studies together, if you're seeing that they all kind of trend towards, yeah, there's a positive effect and it reduces pain, that is the direction, right? So the direction could be good even if the magnitude isn't. No. So a lot of times when we hear low quality evidence, it's we don't understand what's the magnitude of the effect.
Right.
So yeah, and injections, it's no different, right? They suffer from the same problems as the rest of us.
Yes.
Which is that we don't understand the magnitude of it, and but there are people that benefit from it. There's people that don't.
Yeah, I have patients where they have definitely benefited from it, but then I also have patients probably 50-50 that don't, and they're wondering why it doesn't work. But then there's, like I said, I do have patients. I had a patient last month that had one done because she was having just consistent pain into her glute, some pain like down, didn't go past her knee, so it wasn't sciatic.
Well, what do we know about that?
But she did get an injection. So far, is still pain free. But who knows who knows how long that will last?
Yeah.
And so it is kind of diagnostic. Like, okay, they hit the right spot. They hit the inflammation, knocked out the inflammation. But when the cortisone wears off, are we back to square one?
Yes.
So
you bring up a really great thing because that's probably the greatest value of some of these techniques is diagnostically.
Yeah.
So the idea is, hey, we can see on an MRI that you have a disc bulge. We can see that there's some encroachment on a nerve. And we've talked about this over and over on the show that you can see those things on an MRI and it doesn't always correspond with symptoms.
Right.
Well, one of the ways that you can confirm that this does correspond with symptoms is let's do an injection near the nerve.
Yeah.
And if it turns off the symptoms, then we know that that compression is enough that it's causing irritation, ergo, if we go in and do a surgery, a decompression, something like that, probably a better chance of a good outcome.
Right.
So it's better than a surgery. And a lot of times they'll use it before a surgery.
Right.
Just so that you know that we got a pretty good chance of this getting better.
Yeah.
Otherwise, it's kind of a coin toss.
It is 50-50.
Yeah. And there's two other things that make this not my favorite treatment. One of those things is the safety profile of it. So this is the big knock that people have against chiropractic is it's dangerous, right? You're killing people. You're giving people strokes all over the time. We've done other episodes about it, so I'm not going to rehash all that data. But there is an association between cervical manipulation and stroke, and it is an association. There isn't any evidence in the literature that confirms a causal link between getting your neck adjusted and having a stroke. Some people they have dissections, they have strokes. Some people are going to the chiropractor because of symptoms of the condition they're already having. Now, with that though, comes, even though it's extremely rare, very rare, there's people, especially in the social medias, that are like, dude, if you go get one adjustment, you're going to have a stroke.
You'll die.
Yes, there are piles of bodies underneath chiropractic clinics. Yeah, it looks like
It's right next to the morgue.
Yes, it looks like a Native American burial ground, right? Like it looks like Gettysburg, you know. But which totally is not the case. These cases are extremely rare. But you know, we get labeled with it.
Yeah.
But epidural steroid injections have a higher rate of stroke. And
do they really?
Yeah, higher rate of stroke.
Today. Okay.
They have a higher rate of epidural hematoma. So we already went over what epidural means.
Yeah.
What's a hematoma?
Hematoma, no good.
Yeah, no good, no good. Yeah, it's bleeding. That basically makes a bruise, and that bruise can compress the spinal cord, lead to hemiplegia, paraplegia, quadriplegia,
Hmm.
which is fancy words that I paid a lot of money to learn that mean paralysis.
Yes.
Yeah. And some of those cases are permanent. And most of them, fortunately, are transient, but some of them are permanent. And these complications, they happen at a higher rate than they do with chiropractic, certainly higher rate than they do with physical therapy, which is completely safe.
100%
100% safe. Yes. Yes. It's to the point of being completely inert. Now, there's also the risk of abscesses, fungal infections, fungal meningitis.
I was going to say infections. Yep.
I think a few years back, there was a string of fungal meningitis infections that was related to a bad lot of medication. And so, there's real risks that are associated with that. But, the average person listening, they're probably like, oh, yeah, chiropractic, that's a little sketchy, maybe a little bit dangerous. Certainly PT is completely safe. But they don't think about, these epidural injections. So now, even though I said that, they're still like mostly really safe. The serious complications are rare, but depending upon the numbers that you look at, it's anywhere from like 8 to 400 times more common to have a complication with a spinal injection than a chiropractic injection.
Wow.
Yeah.
That is not what I expected.
Yeah, it surprises a lot of people.
It sure does.
Right?
Yeah, because like, oh, you need to go get a steroid injection.
Yeah.
Wow.
And I think that when people talk about it, they do it with such a straight face that it's like, hey, we're just going to do that. We do them all the time.
Yeah.
And they're not lying.
Right.
Because most of the time things turn out very well. There are some times when people can have, increased nerve pain or bad reaction to it. So that's one of the issues. It's not as safe as other. It's still considered conservative spine care.
Yes.
But it's not as safe as other forms of conservative spine care. So you should not rush right out to get.
Shouldn't be your first choice.
No, and there's no guidelines that would put it in that place.
Yeah.
Yeah. The people who probably should be referring for this, if it's necessary, would be people like you and me, who are first line, according to most major guidelines, whenever it comes to back and neck pain. So, and then with safety too.
Yeah.
If I may,
please.
The neck and upper back are the most risky areas. So most efficacy and safety for the lower back. The riskiest place is going to be neck and upper back for those injections.
Like
so.
Meningitis, because much closer to the brain.
That's what they say for most people. There are some people that, depending upon where their head is in relationship to their gluteus maximus,
their buttocks.
Yes. Then the low back in that case is much closer to the brain. You all probably know a person that I'm talking about. It's a condition we wish was more rare. However, what do they call it? Cranial rectal inversion? Yes. Should we talk about this as a cranial rectal inversion therapy?
Yes. Can Keenan help with that?
Yeah, I hope so. Yeah. Yeah. In that case, meningitis is the cure. Oh my goodness. So that was one thing. So there's the safety portion.
Yes.
The other portion is the cost. Now, Kathy.
Yes. Let's talk about this.
On in capitalism, on the open market, what would you pay for a nice epidural steroid injection? Like, what would that be worth to you? Now, last time you guessed there was 100 million of these being done. I'm going to give you a clue.
Even close.
It is less than $100 million a shot.
It just seems like there's a lot of people getting steroid injections. So I thought it was 100 million.
Well, there's 9 million people.
Yeah.
I'm going to kind of ballpark this.
Yeah.
$134 billion spent every year on spine care. Okay. There's 9 million of these injections. Chiropractic accounts for about 6 billion of that. Okay. Physical therapy, about $25. No, I don't know the number for physical therapy. I don't know if it's been done. I imagine it's probably similar to chiropractic.
Probably close.
Maybe a little more.
Yeah.
Okay, so how much do you think?
So what was the what was the total amount spent on spine
134.
care? Okay.
134 billion.
And chiropractic's
6 billion is that.
So PT's 6.
Yeah, sure. Okay, so there goes 12. So we're down to $122 billion. And there's 9 million of these injections done.
And
now leave some room for surgery, okay? Because that's part of it.
Oh,
but injections,
surgery's at least 100 billion,
maybe. But
spine. So how much per injection?
Per injection.
Well, it's more than 500. It's not what I would pay.
Yes, it's definitely more than
500.
It's more than 500.
Yeah,
it's gonna be enough to satisfy a lot of people's deductibles. Yeah, it's $1,200 on average
per injection.
Yeah, for one injection, it's about $1,200.
I think we're in the wrong business.
Yeah, so to go on average to go to a chiropractor, if you're paying cash out of pocket, it's $67, and so you can have one spinal injection or 18 chiropractic visits, and it's probably similar for physical therapy. Although you guys are ballers. Let's say it's $100 for you.
We're about 100.
Yeah. So that's between a dozen and 18 visits with a chiropractor or physical therapist, or one shot, and your results are the same.
The same exact.
The same results with just a little more risk, just a little bit. Like if
touch of death.
If risk was a lime, you just like whoop, give it a little squeeze, right? Okay, but nerve ablations.
Yes, let's talk about nerve ablations.
Yeah.
These are fascinating.
Yeah, they're 4 times as expensive as spinal injections. Yeah. And no more effective. Yeah. So you can get 80 chiropractic visits for the cost of one nerve ablation.
Wow.
Yes, and at 6 months, there is no difference in outcomes. And that is pain as well as disability.
No difference in 6 months?
Yeah. So the best long-term outcomes of conservative care for spine care is physical therapy. It's exercise. At about 12. So everybody does pretty good under 6 months, right? It's kind of a toss-up. Go to chiropractor, physical therapist. You can get your shots. You can do your drugs, whatever, right? You can, burn sage. I don't know what you do. You can think happy thoughts.
Absolutely.
Yeah. Under 6 months, it's anybody's game. At about 6 months, chiropractic is still doing pretty good. 12 months, physical therapy's left pretty much everybody in the dust because at some point you got to rehab, right?
Yeah.
And you don't have an active inflammatory issue. You have a how would you call it?
Chronic dead glutes.
Yes. Chronic gluteal death. Right. And so that is a big deal. So you could go, let's say that you're paying $100 a month to go to physical therapy, which that's extremely conservative.
That would be cheap.
Right?
Yeah.
Yeah. You could do a year of physical therapy for the same price as one shot. That one shot is going to give you maybe a couple weeks to 3 months of relief, and physical therapy would give you a year of relief, and that's according to the studies, right? Or geez, you could just all you can eat chiropractic, chiro buffet, right? So yeah, it's a crazy thing. So my question to you, Kathy, is given all this, why don't people love me? Why do they hate chiropractors?
They just want to hate on you guys. What is it about what you do that brings out the haters?
So the crazy thing is I asked that,
Yeah.
and instantly some skeptic popped into their head. Oh, well, what you do is a complete sham, and it doesn't beat placebo. It's but rewind a little bit, because we had this discussion.
Yes.
It's all about the same.
Yes.
None of the evidence is amazing. There's high heterogeneity. So Get rid of that. Get rid of
that
that
is
argument. It's not
yeah.
good. Oh, well, it's like chiropractors out there killing people. No, 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 no.
No.
We already had that discussion too,
Yeah.
right?
Yeah.
Then they want to bring up the ghost in the room, right? Chiropractors are weird because they think that, the founder saw a ghost. And, so there's just
And you can treat allergies.
right. Oh, it's the wild claims. Yes, the
Yes.
pseudoscientific claims
Yeah.
or the misleading
Mm-hmm.
misinformation claims.
Mm-hmm.
So misinformation like, spending $5,000 for a treatment that's going to last you for 6 weeks is a good investment.
Mm-hmm. Mm-hmm. It's our society though too. Like
Yeah.
we will pay money to get that quick fix.
Yeah. Well, and so here's another interesting thing is what you believe matters.
Yes.
It's a huge part of whether you
Mhm.
get better or not. I think that we've had this conversation before too. And so the patient's buy-in to a treatment matters.
Mm-hmm.
Have you had patients that are just like, hey, can we just get this done so that I can go ahead and skip to surgery?
Get my MRI.
Yeah,
Yeah. All the time.
Yeah, let's just knock this out so I could get surgery.
Yeah.
I think we talked about that on our Google episode,
We did.
right? And so it's patient beliefs matter a lot, and there's some people that they just have supreme faith that as long as there is a needle or a scalpel involved, that is going to be the fix.
The physicians are the experts.
Yeah. And it's great marketing for physicians, and it's also terrible marketing for physicians.
Yeah.
And the reason we believe that is, I mean, you look at our culture, you look at our media and stuff like that. We've got shows like House. We got shows like Griffin keeps watching Grey's Anatomy.
Oh yeah, he's back.
Can you believe that? Can you believe that show is still on the air?
I cannot believe that still producing episodes.
Yeah, it's crazy. It's like so Meredith
It's
is
the same thing. She's still on it.
Yeah, and she's like participating in Bring Your Granddaughter to Work Day.
Oh.
She's got to be right. She's like, this is my grandson Michael, and here we are.
He's in med school.
Yeah, right. Yeah, he's a third-year resident now. It's like, why is that show still in the air? But you have all these shows, and they make physicians into heroes.
Yes,
and which isn't inaccurate. No. I think physicians definitely are heroes.
They save lives.
Yes, but the Hollywood version of a physician, it's not the same as a real life version of a physician, and so I think that's kind of unfair to them. It places a lot of pressure on them, and I think what we see right now is we're at an all-time low of people putting trust in the medical establishment. And I don't think that is physicians' fault.
No, it's the system.
It's the system.
It's the system.
It's the system.
And to be fair, I see people with a lot of pain every day, right?
Mm-hmm.
Nerve pain is at the top of the list.
It's a different beast.
It is a different beast. It's sometimes intolerable.
Yeah.
You can't sit, you can't lay, you can't stand, you can't do nothing.
What about people who come in and they say that they have nerve pain and they just don't know, right? Like, yeah, I think it's a nerve back here.
Yeah,
yeah, you would not be so casual, sir.
You would know.
Yeah.
This is nerve pain.
Yeah, right. People have nerve pain. They don't come in wearing jeans.
They do not.
They come in pajamas.
They have not slept.
They have not.
They have not slept. They're barely eating.
Yeah.
They're drinking something just only to take meds.
Yeah. Women who have nerve pain don't show up in makeup. They don't.
No.
You're in survival mode.
Yeah. Yeah. So, that is tempting when you're in that much pain. You just want it to go away.
Yeah.
So the idea that this shot could at least even cut it in 50 to 50% is probably people are like, I will pay whatever it takes.
Yeah.
Right.
Yeah. Or I will have my insurance pay whatever.
Yes.
it takes,
my insurance will pay whatever this takes.
Yeah. Well, and that's the thing that's confusing to me too, is insurance companies, they have access to all this data.
Yeah.
Why do they keep paying for these injections?
It's so interesting. And when they cut me off after 9 visits, sorry, that patient with back pain, 9 visits.
Yeah.
They're not better yet. They can do their exercises at home.
It's stupid.
Instead, I'll pay $1,200 for this one shot.
Yeah.
That has a 50-50 chance.
And it's so confusing to me because Like there's all these videos on social media now where they show doctors who are live streaming basically their peer-to-peer calls.
Oh, yes, I've
Yeah.
seen
Have you
those.
seen those? They're amazing. So you
Yes.
have people that
Mhm.
they don't have the qualifications to
Mhm.
be considered a peer
Right.
with the person they're talking to. You have doctors who are trying to get authorization for procedures mid-procedure.
Yes.
It's
It's
like
outrageous.
that's so stupid,
Yeah.
right? And so there's incentives to insurance companies to support some of the insanity.
Mhm.
And it's like I wonder what would healthcare look like if you had no insurance.
Yeah.
I think across the board it would be far less expensive.
Mhm.
Um,
No doubt.
w- I mean, one of the reasons that my prices are what my prices are is because of insurance,
Yes.
right?
Yes.
And it's because of averages of
Mhm.
copays and things
Mhm.
like that.
Mhm.
But if people were paying market value for what I do,
Mhm.
then I might make a lot less money,
Yeah.
right? And so if you're one of my patients and you're listening to this, just fast forward past this part.
Thank you.
Fast forward.
Thank
No.
you for your
Yeah.
insurance.
So, but across the board, like that's the way that it is. And people don't understand too that I mean, even what I'm saying about this, it might be even a little bit illegal
Mm,
because providers aren't allowed to talk with each other
not
about
really
prices.
what they're getting paid.
Yeah, it's
Yeah.
price
What do
fixing.
you get paid? Can't
Yeah,
tell
it's
you.
price fixing.
Yeah.
And so your associations can like collectively bargain for you and
Right.
everything, but like the whole thing, it's so crooked and it's so ironic that the system that we're relying on to make us healthy is so
It's
dysfunctional,
so dysfunctional.
toxic, and unhealthy.
It is the lowest it's ever been.
Yeah.
And I mean, we've
Yeah.
known this crisis has been coming and we've done nothing
Yeah.
about it.
Yeah.
Nothing
Well,
about it.
the thing that we've done about it is we've
Oh,
involved politicians.
yes. This is true.
We've involved
Nothing good
politicians who can be
happens
bought.
when
And
they get involved.
yeah, I don't know what has to happen
Mhm.
to change it, um but just to get back to like when I talked about the trust being so low
Yeah.
in medical providers, I mean, they don't deserve that because uh your doctor is a good person. There's some people that get into medicine because they want to make a lot of money. You can make a lot of money, but that's maybe 1% of them.
Yeah.
Most of those people are in it because they love helping people. They love the idea that they can help save a life, that they can make a life better, they can make life longer, happier. They love kids, they love old people,
Mhm.
and that is what the average doctor is
Mhm.
like.
Mhm.
But it is not what the system allows them to behave like,
Right.
which is like it's soul crushing.
Yeah, it really is. Doctors, I feel like, are naturally problem solvers, and they
Hmm.
do not have the time to solve the problem for the patient sitting in front of them. They don't. They get
Hmm.
15 minutes and they got to see 25 people a day.
Yeah.
At what point do they have time to research or phone a friend, doctor friend, and say,
Yeah.
"Hey, have you seen this
When do
before?"
they get to call Meredith Grey?
Yeah, that's
Get some
right.
answers,
Yeah.
right?
Yeah, I mean, that's what they want to be able to do, but the
Hmm.
system does not allow it.
No, and in our community here, like we're losing doctors.
Yeah.
Corvallis is kind of
Mhm.
I'm getting
Mhm.
nervous
I
about
agree.
living here
I
because
agree.
as I get older and I need more appointments and stuff, like right now in my car, I've
Mhm.
got like this great big jug.
Yeah.
You know what the big jug is? Some people are like, "Oh, I've
Oh.
gotten that jug."
Oh.
Yeah, it's the
What is it?
colonoscopy jug,
Oh, is
right?
it
Yeah.
time?
Yeah, it's like you got to drink all this stuff and everything like that. It's like, "Oh
Oh,
boy."
no.
So it's like, yeah, I'm just at an age and stage where
Yeah.
this ride needs more maintenance, I guess. And so it's like I'd be lying if the thought hadn't crossed my mind, is there a better or a safer place to
Mhm.
live? Because like you get some of these big
Mhm.
hospital systems
Mhm.
coming in and everything,
Mhm.
and we have doctors that are just like, I don't know if I can say in this community
Yeah.
because I don't get to practice actual medicine.
Right.
And that really worries me,
Mm-hmm.
right? Because what if I need something?
Yeah, exactly.
Yeah. I have things like some of these things I need to get, like I have to get referred to Salem
Mm-hmm.
because they can't get me in here. I can't refer patients to a neurologist here,
And there's
which, uh,
there's
and that's really a like a real paradox too, because there's sometimes when people are like, chiropractors claim that they can just fix everything and treat everything, and you're pricing outside of your scope, and it's like, okay, I hear you. So in this situation, what's the right thing to do? Should I refer them to a neurologist? Okay, yeah, I agree. Can I refer them to a neurologist? Not here.
no.
I can't.
Yeah.
Right? You have to go see your primary care doctor
Mm-hmm.
in 6 months.
Mm-hmm.
And then they have to refer you to a neurologist
Mm-hmm.
that you can see in 4 months. And hopefully 10 months from now,
Mm-hmm.
your nerve damage is not irreversible.
Right. You
So,
can still move your arm.
mm-hmm.
Yeah, more and more of my patients are going to Salem or Eugene if they need to have surgery because wait times around here for surgeons are 6 months, 8 months.
Yeah,
Yeah, it's a big problem.
it's insane.
Mhm.
So,
So if we had universal health care, because those people wait a long time.
it's almost like we have the capitalist version of universal healthcare. Oops. Ooh, just ran into the microphone. Yeah, and so it's very frustrating. And the other thing too is that we brought this up before. We have a shortage of doctors in the country. We're behind by like 120,000. There's no way that we can catch up, right? That's why we need nurse practitioners and PAs. I was talking to an MD friend of mine who just didn't have anything nice to say about nurse practitioners. It's like, what's going on?
Yeah.
So first ticket to the moon. I will take that trip. I know that there's no health care there.
Just gonna start over up
there? Yeah. It's like, then at least I'd understand. Oh, yeah, the healthcare here sucks because I'm one of 6 people. So, anybody need a spinal adjustment? Oh,
Planting
gosh.
the flag.
Yeah, this is just the cheeriest episode of the Pitch podcast that we've ever had.
Gloom.
Yeah, we started, don't let anybody stab you in the spine, and now it's like, P.S., we're all going to die. No, but
keep your heads up out there, though.
Yeah.
It's going to be okay.
Well, and solutions, I think, will come because they have to.
They have to.
Yeah.
Our back's against the wall. And
is that a pun?
No pun intended.
No
All
pun.
the puns intended.
Yeah.
Yes.
But I think this is one of the reasons that clinics are important, right? So like what you do, your clinic is important. What I do is important because we need to keep primary care doctors and specialists seeing the people that they need to see.
Yeah.
Right. So if somebody can be helped by physical therapy, they should be at physical therapy.
Yes.
They should not be at a primary care doctor.
Yes.
Because we need primary care doctors helping people who are sick, who have internal like organ conditions and stuff.
Yeah.
We need to help them to stay in their lane, right? By staying in our lane. And one of the worst things that we see is whenever you have these professions that are infighting. And there's some stuff that we could probably just let go of from a financial standpoint. Like we don't need to be pushing so many epidural steroid injections.
Yeah.
Right. And like it would be good if they're like, hey, maybe you should go to a physical therapist or a chiropractor or whatever you prefer first. And if they think it's a good idea, then yeah, get this injection. And that might help you to know, do I need a surgery? So
I wish we could normalize people when they have pain thinking, you know what, I'm just going to call my physical therapist or chiropractor. How many times do you get? Well, I get this a lot. Well, it took me 6 weeks getting my primary care to get a referral here.
Oh, gosh.
And I always had to tell, you don't need a referral.
Yeah.
Just call me. Just call the clinic. We'll get you in.
Yeah.
I want to get a referral. You don't need a referral. So that stigma.
I could have been better already.
Yeah.
You could have been better already. Yeah. And I think one of the things like the domino effects of that because I know chiropractic, we get a bad rap for there's doctors out there that want to have these never-ending treatment plans. Like I want to see you for 40, 50, 60,000 visits or something like that. Well, if we're seeing the people that we should be seeing, we don't have room for these long treatment plans.
Right.
I had a patient this morning who they went to like one of these like fitness classes, lifting something heavy, and they came in and they're already improving. Like they've gotten better since it started. We did an exam, determined that there was nothing dangerous going on, right? It seemed like just a strained back. And so the treatment plan was, hey, you should start lifting again, right? Let's do some graded exposure to lifting. Like don't go back to exactly the thing that got it, but let's start lifting some stuff again. I'm going to give you some exercises. Let's get your back adjusted so that we know that it's just moving like it should. If you did nothing, it's probably going to get better on its own, but let's just try and speed that up and give you some confidence that you can go back to doing something that's healthy for you, which is exercise.
Yeah.
Right. And so, of course, I want to see her for 18 visits.
Yeah.
And no,
I thought maybe 36.
No, we're just planning on like 3 or 4 visits.
Yeah.
Right. And so, and that's what it should look like. And there's some people who want more. There's some people who need more, and we do that. But in the meantime, we don't have to do anything that's like really like over the top.
Yeah.
And that is what keeps enough. That's what keeps enough healthcare available for everybody. Yes. Laughing about off-camera stuff.
Sorry. Trying to keep it quiet. It's time for a game. I think it's game time.
Yeah, I like that. I get some water in my mouth and you say it's time for a game. Let's do this. All right, Kathy. Let's see if you've been paying attention. We're going to play a game that I call Spinal Tap.
Okay,
no,
let's do this.
Not the movie, unfortunately.
All right, darn.
Is this a real procedure or did I just make that up?
Okay, love it.
And it's pretty much played how I just said.
Okay.
All right, you ready?
Let's go.
Epidural steroid injection.
Real.
That is real. Very good. Oh, and something that I meant to bring up about this. One of the things that's interesting about epidural steroid injections is they can't even really tell if it's the steroids.
Oh.
There's a thought that it might just be the saline or the local anesthetic that's injected.
Have they done sham?
Yeah.
They have.
And that is why it doesn't perform well against sham treatments. So you might not even need that at all, right? You might just pinch people in the back and be like, boop, there you go. Does that feel better? How's your foot drop now? Is it better?
Look at that.
Yeah.
It's moving.
How's your tricky leg? Ooh, that's a good callback. All right, how about this one? Bilateral spinous process block.
Bilateral spinous process. No.
Numbing the bony bumps that you can feel down your back.
No.
Yeah, that's fake.
Okay.
There's no value in that.
I passed that one.
Okay, what about this? A stellate ganglion block.
Stellate? Spell that, please.
Stellate.
Stellate. What?
Ganglion.
Okay.
Block.
I'm on board with the ganglion.
Mm-hmm.
I don't know if I know about stellate, but so we're gonna go with it. It's real.
It is real.
What's
yes.
a stellate?
Stellate. Gosh, I think that means like star shaped.
Yeah.
Yeah.
Okay.
And the ganglion is a structure right near the spine.
I did learn that one.
Yeah. Mm-hmm. All right. Intradiscal helium decompression.
No.
It makes you talk like this. Yeah, we're not injecting inert gas into. Although I did see that they're experimenting with injecting substance into nucleus pulposus.
Oh.
To like pump them up. Yeah.
Make us taller.
Yeah. Well, just to help with the yes,
okay.
Exactly.
All right.
But the thing is, if you have a decrease, it's probably because you have damage to the fibers around that, and so it's like, how are you going to keep that stuff from just leaking out the side? Anyway, we'll see. It's being tested in other countries. Medial branch block.
Yes, real.
Okay, absolutely real. That's an easy one. What about a ganglion impar block?
I don't know what an empire is, so.
That is one that is at the very bottom of the spine, like down around the tailbone,
Okay.
the sacrum area, coccyx. Real or fake?
I'm gonna say fake.
That is real. That is real.
Okay.
And that's its real name.
Empire.
Let's do a couple more.
Okay.
Oh, how about this one? Dural sheath microbubble therapy.
No.
Okay. Yeah. I don't even know what that would be. We already did radio frequency ablation. You know, that's real.
Yep.
What about an epidural blood patch?
Blood?
Yes, an epidural blood patch. You want the description?
Yeah.
A small amount of your own blood injected into the epidural space to seal a spinal fluid leak.
Sure.
Yes, it
Yeah,
is real.
It's real, huh?
And in fact, I have somebody that I want to bring on who wants to talk about cerebral spinal fluid leaks.
Ooh,
Yeah.
okay.
Yeah, as a guy that I went to chiropractic school with.
Okay.
Okay, we'll do one more. Kyphoplasty.
Yeah, sounds really dangerous, but I think it's real.
It is real, yes. It's a balloon plus bone cement to stabilize a compressed or like a compressed vertebrae. So when you have a compression fracture and it wedges, they balloon and then they put cement in order to fix your kyphosis.
Yeah. Okay.
Really cool.
Okay.
All right. That's the game.
I love it.
Yes. A lot of big words in that game. So we're going to have to charge people extra for this episode. Takeaways.
Okay. Takeaways that the evidence for spinal injections is the same as the evidence for chiropractic.
Yeah.
But you can get more chiropractic, more bang for your buck.
Yeah.
With chiropractic.
Yeah. And
$5,000 per nerve ablation.
Yeah. And I hope that's a take home for a lot of people is that in our broken healthcare system, we need to insist on cost efficiency.
Yes.
Not cost efficiency for insurance companies, cost efficiency for the whole system. Because when we're using the most expensive treatments to do things, it is the people who pay. It is not the insurance companies. We pay in premiums, we pay in taxes, we pay in administrative costs.
Yeah, we're paying it.
Absolutely.
Yes.
Yes, we are paying out the nose.
Yes.
Because insurance companies are not in the business of losing money.
No, they are not.
They
like
are
casinos.
Not. Yes, exactly. All right. Well, good stuff. So, shout out to our sponsors.
Yes.
Body Health Chiropractic and Wellness Center. Woo!
Yeah, let's go.
Corvallis in Albany.
Yep.
And then
Encore Physical Therapy only in Corvallis.
Yes, but PT so good, you're gonna want
more.
A lot more. Yeah, even at $100 a pop.
At least 36 visits.
Yeah, at least 36 visits. You don't need insurance approval, right? It's America. Okay. And also, please subscribe to our podcast.
Yes.
Whether you're on Spotify, Apple Podcasts. I had a patient who pulled us up on some weird podcast app that I've never seen before.
Yes.
Apparently, we're on that. And we would love a rating, right? Like a good 4 or 5 star. Just kidding. Just 5 stars.
Just 5.
And if you feel like we deserve a 1-star rating, just give us a 5-star instead.
Add 4 to it.
Yeah, because if you don't see the value of this, you probably can't count anyway. No, like a great rating would be helpful. It helps to spread the word. And one more thing, like we want comments and
yes, we love feedback.
Yes, if you go to the new website, I didn't talk about this. I updated the website, so there is now a wiki. Right? You can get on and you can see all the little like running jokes and stuff that we have. There is a full episode guide, a directory of all the guests. We have all of our sponsors, affiliate links, all that kind of stuff. And there's a spot where you can vote on what you want to see on the Pitch podcast. And you can send us recommendations on shows that we'll ignore and we'll just do what we want anyway. No, just kidding. So yeah, pitchpodcast.com. That is Pitch Podcast.
Pitchpodcast.com.
Can you say it, please, Kathy? Holy smokes. Pitchpodcast.com. Yes. Go there, look around. It's a really great time. Go there with your friends. Get a bunch of friends
Definitely
together.
on a Friday
Pop
night.
some popcorn.
Yes.
Yeah, gather around
the YouTubes.
a MacBook, an iPad.
Yes.
Right. Even if you have Android, we'll still take you.
Yeah.
Yeah. So, and the most important thing that we should bring up is there is no I in pitch.